Hi, my name is Dr. Ryan Maves, and I just wanted to thank the conference organizers for the opportunity to speak to all of you today. I'm an infectious disease and critical care physician at the Naval Medical Center in San Diego and an associate professor at the Uniformed Services University in Bethesda, Maryland. And I have the chance to talk to you all today about a clinical trial update for COVID-19. Just in terms of disclaimers, I have no relevant conflicts of interest. I will be discussing off-label and investigational agents. I am an investigator on the NIAID adaptive COVID-19 treatment trial that will be referenced here, but don't receive any financial benefits from that. And the opinions expressed here are mine and do not necessarily reflect the official opinion or position of the Department of Navy, Defense, or the U.S. government. So we have, in the last several months, seen a lot of drugs come and go in terms of the treatment of COVID-19. Early on, a lot of interest in antiretrovirals such as lopinavir/ritonavir, influenza drugs such as favipiravir, and then anti-inflammatory agents ranging from tocilizumab to convalescent plasma to glucocorticoids. So far, in terms of the impact of these agents on mortality, the only drug that really has a proven benefit on mortality at this point are glucocorticoids. Remdesivir is still a work in progress, and there's very limited data for anything else. When we look at the clinical trial landscape for COVID-19, as of 2:10 p.m. Pacific time on the 27th of August, there were 1,135 interventional trials for COVID-19 that are active, recruiting, or completed on clinicaltrials.gov. The majority of these in the United States or in Europe and the United Kingdom, with a large number of others in China, Canada, Mexico, and elsewhere. So the problems we face are that we have three major guideline panels that have posted interim guidance. The NIH's guidance is updated very frequently and usually reflects the most recent data. There are other guidelines issued by the IDSA, by Surviving Sepsis, but we have a very limited number of known effective therapies, and this puts practicing doctors in a bind. So in general, these recommendations are focused on available data for common interventions like remdesivir, for example, or have really emphasized core critical care issues like low tidal volume ventilation. And that, when we look at clinical trials and the landscape for COVID-19, might be the most important takeaway, is that we've tried a lot of things for this disease. And we do have a couple interventions that are very promising. We do have a couple interventions that might be promising in the future with better data, but that our focus should really be sticking to the basics, sticking to the essentials. So if we have a bottom line up front, this is a military term, the bottom line up front, or the bluff. These, I would say, are the four major points that we need to take forward when we look at the clinical trial landscape and what do we do for patients with COVID-19. So infection prevention precautions, generally favoring enhanced contact precautions with some sort of advanced respiratory precautions such as an N95 or a PAPR. Focusing on the basics, so rigorous attention to infection control, low tidal volume ventilation for the mechanically ventilated patient, standard VTE prophylaxis for now with vigilance for clinical VTE. It is a common practice, and I think within the reasonable standard of care, to use kind of augmented prophylaxis such as a 0.5 milligram per kilogram dose of enoxaparin twice daily, but so far that approach has not yet been validated prospectively. Looking at volume status, looking at hemodynamic management. For patients with hypoxemia, consideration of 5 days of remdesivir and up to 10 days of dexamethasone. Other strategies such as convalescent plasma, higher dose anticoagulation, these are all investigational, and these are all going to await confirmation in future clinical trials. So when we look at antiviral therapy, what drugs do we have to treat the virus itself? Really, it's a very short list, and it begins and ends, for the moment, with remdesivir. This is a viral RNA polymerase inhibitor, originally participated in a large clinical trial as part of Ebola therapeutics. It didn't work great for Ebola, but has activity against coronaviruses. There are multiple ongoing trials currently in progress. It is available through an emergency use authorization, and it has been submitted to the FDA for approval. So the first RCT of remdesivir was conducted in Wuhan early in the pandemic. Relatively small trial, 237 patients with a 2-to-1 allocation, mostly men, with a lot of concomitant other agents such as antiretrovirals, interferons, corticosteroids permitted. Relatively small but reasonable numbers of patients on mechanical ventilation. The trial was stopped early with a resulting reduction in statistical power and ultimately did not find any clear benefit to remdesivir. There was A trend towards improved clinical improvement in the remdesivir arm compared with the placebo arm. Again, 65% improved by day 28 versus only 58% in the placebo group. But again, small numbers did not meet significance. Also appeared to be a shorter duration of invasive mechanical ventilation in survivors, which again did not meet statistical significance. So that gets us to the NIAID Adaptive COVID-19 Treatment Trial, or the ACT, and this is an ongoing study. Act 1 was a trial of remdesivir versus placebo. This was 1,063 patients at 68 international centers. The primary outcome of time to clinical improvement, meaning one of these three groups: hospitalized but not requiring supplemental oxygen or needing medical care, not hospitalized but with limitations in activities requiring supplemental oxygen, or not hospitalized with no limitations. So this trial completed in April of this year. An independent DSMB evaluation on the 27th showed a faster recovery time with remdesivir. The complete analysis of this trial has been submitted for publication, or is being submitted for publication, I should say. There are follow-on versions of the study. Act 2 is remdesivir plus or minus baricitinib, a Janus kinase inhibitor. Act 3 is enrolling now. That's remdesivir plus or minus subcutaneous interferon beta. So looking at the preliminary report for Act 1, what you basically see is that there's a decreased time to recovery with remdesivir. So reducing the time of clinical illness to recovery from 15 days to 11 days in the patients who received remdesivir. Now this benefit, and we can see it on this chart here, is most marked in Group C, which is the lower left-hand corner there. And what you can see is that patients receiving supplemental oxygen, so by nasal cannula or by face mask, had the greatest benefit and recovered most vigorously. This is not unlike what we see with other antivirals, such as oseltamivir being the most obvious example, that in patients receiving more aggressive forms of oxygen therapy, such as high-flow oxygen, such as non-invasive ventilation, we see a much more limited benefit. And Table E here illustrates that, how there's really not much of a difference between remdesivir versus placebo in patients who are starting therapy on mechanical ventilation. There was a mortality reduction overall, but it did not meet significance. This benefit, once again, was most marked in patients who were requiring only supplemental O2, not those folks who are on the vent. And this just continues to illustrate that point. This is mortality. Group C is folks who required only supplemental oxygen. Group E, below there, are people requiring mechanical ventilation. So there are a number of other antiviral agents available. They have not yet shown benefit. Favipiravir is an anti-influenza agent with some activity against other RNA viruses. It's licensed in Japan. Umifenavir is an inhibitor of viral fusion. It's licensed in Russia and China. And then lopinavir-ritonavir is an older antiretroviral that, to be fair, I haven't actually used in any patients since I was an ID fellow. A protease inhibitor, but has in vitro activity, but ultimately hasn't been shown to be effective in randomized trials. There is some conflicting but interesting evidence regarding interferons and whether interferons can help. This was a open-label randomized phase 2 trial here published in Lancet that looked at patients receiving interferon beta 1b plus lopinavir-ritonavir, which we know doesn't have any efficacy, has some in vitro activity, and then ribavirin. And I guess it's sort of a truism in ID that no viral infection is totally untreatable until we try to give it ribavirin. But the patients who received this triple combination, and I suspect that interferon would be the active agent, did show some evidence of improvement. And in this table here, what they measured that in terms of NEWS2 scores and SOFA scores. Mortality in the study was very low, but people did seem to get better faster. So interesting. We're exploring this further in Act 3 in combination with remdesivir. So what about immunomodulating agents? So a lot of attention early on was given to IL-6 antagonists, mainly tocilizumab, to a lesser extent sarilumab. This was a result of the observation that there was a HLH, or cytokine release syndrome-like syndrome, seen in patients with severe COVID, or with COVID with critical illness rather, who had elevated IL-6 levels, elevated ferritin levels, and this was reminiscent of the cytokine release syndrome that we would see after following, for example, a CAR T-cell therapy. There were some anecdotal evidence of benefit, but what's turned out is that the manufacturers of tocilizumab and sarilumab actually moved into phase 3 trials in critically ill patients. Those were both by Roche and Regeneron, and both manufacturers terminated their trials due to lack of benefit. So I think that it's unlikely that most patients are going to benefit from tocilizumab or sarilumab. I suspect some of us have seen some cases where there may have appeared to have been some benefit, but I think for the time being, IL-6 antagonists don't appear to have a role in the treatment of COVID-19. How about convalescent plasma? I think we've all read in the paper about how FDA issued an emergency use authorization for convalescent plasma. The biggest data series, we'll talk about it in a minute, but there were some early small case series. There is kind of a long history of people trying this for a variety of severe infections. It's been, NIAID actually did a randomized trial of this for severe influenza just a couple years ago and did not show any benefit against that disease. There have been some evidence of efficacy for a few less common diseases like Argentine hemorrhagic fever. And some early small case series early in the pandemic suggested some evidence of benefit. These were in JAMA and in the Proceedings of the National Academy of Sciences. And this is just a randomized trial conducted in China showing that basically patients with severe disease, meaning hypoxemic but not critically ill, there did seem to be some evidence of benefit, but this study was small and relatively underpowered. So more recently, this is a preprint of an article by Dr. Michael Joyner and colleagues out at Mayo looking at patients who have received convalescent plasma through an expanded access protocol in the United States. And over 70,000 people have received plasma under the auspices of this or similar programs since the beginning of the pandemic. What's interesting about this data, and this is all observational, is that there's a large proportion of patients of Latino descent, of African descent, a very high prevalence of obesity among the severely ill, and a lot of confounding factors. For example, you can see that 30% of patients received remdesivir, about half of them received corticosteroids. So a lot of things kind of going in the mix that makes some of this data hard to interpret. It is interesting in the observational data that they're suggestive of a dose response, that patients who had higher titer plasma appeared to, that meaning higher titers of anti-SARS-CoV-2 antibodies, appeared to have lower mortality, and patients treated earlier seemed to do better than patients treated later. There are more than one way to interpret this, though. There is more than one way to interpret this, which could be that perhaps early treatment has no benefit and late treatment actually has harm. So again, a lot of this needs to be validated prospectively, and it is interesting that the NIH COVID-19 guidelines panel thus far is not recommending convalescent plasma be given routinely, despite the FDA's issuance of the EUA. So I think there's still some work to be done here. How about other immunomodulators? Well, so corticosteroids. Early on, this had a lot of controversy, and I have to admit, as an infectious disease doctor, you know, the idea of treating a viral pneumonia with steroids is kind of like fighting a forest fire with kerosene. And we've seen observational data that this can be harmful in cases of, say, severe influenza. But, you know, still. So there was some early Chinese data. This is out of by Dr. Wu and colleagues in JAMA Internal Medicine, 84 patients with ARDS. Observational study, but it appeared the patients who received methylprednisolone as therapy did better. So this led to the recovery trial, which is an open-label, multi-arm randomized trial being conducted in the United Kingdom in patients with clinically suspected or proven SARS-CoV-2 infection done in 176 UK hospitals between March and June. In this part of the recovery trial, patients received dexamethasone, 6 milligrams times 10 days, and then they're compared to patients who received the standard of care. There's a total of 6,400 patients approximately with a 1-to-2 allocation of dex versus standard of care. It is interesting that 8% of the standard of care group received dexamethasone as well. It's also interesting that only 5 patients received remdesivir. That's a function of the time that this trial was done. It's also interesting there was a very, very high baseline mortality in this study. So 26.2% of standard of care patients who did not receive mechanical ventilation died. So that limits a little bit the interpretation, both the open label aspects and the very high baseline mortality. But nonetheless, what we see here, and this is sort of the opposite of the remdesivir story. Now with both remdesivir and dexamethasone, we see no evidence of benefit, and in the case of dex, maybe even a little bit of harm in patients who receive dexamethasone. That is, if you have COVID-19 and pneumonia, but you are not hypoxemic, dexamethasone did not benefit you. But if you look at patients who require invasive mechanical ventilation, there was a pretty substantial mortality benefit. So similar, but sort of the mirror image of remdesivir, if you will, where requiring supplemental oxygen, those patients did better than patients on mechanical ventilation. Despite similar inclusion criteria, dex had more benefit for those on the vent already. And this is just a nice little plot here demonstrating that among all patients, there was a benefit to dexamethasone, but that benefit was confined only to people who either required supplemental oxygen through non-invasive means or who were mechanically ventilated. And as you see, there's a trend towards harm in patients who did not require supplemental oxygen. So this is a more recent study. This is a smaller phase 2b study that was just published ahead of print in Clinical Infectious Diseases. This was done in Manaus, Brazil, which is in the Amazon basin, with a 5-day course of methylpred. So at a comparable dose to the 6 milligrams of dexamethasone. And what they found interesting was a mortality benefit in patients who were greater than 60 years of age, but not seen in younger patients. They had a pretty large number, 33% of patients were mechanically ventilated. They had a 38.2% mortality in the placebo group. So they didn't see quite the same benefits, but again, this is done in a very different setting. They are a referral center for a very large, largely rural part of Brazil with very limited transport capability. Their patients were often much, much sicker by the time they got to them. And obviously there are a lot of confounding factors, concomitant tropical diseases, other things that could blunt the benefit of steroids in their population. So interesting, but a much smaller trial than recovery. So there are a number of other therapies out there that are being looked at. Anakinra, which is an IL-1 inhibitor, baricitinib, which was studied in Act 2. The evaluation of that is still ongoing, or the analysis of that is ongoing. Thalidomide, eculizumab, Regeneron, who makes cerulumab, is also studying anti-SARS-CoV-2 monoclonal antibodies, and many, many, many more. So there's a lot to know. But in summary, if I had to summarize, if someone had to ask me, how do you treat COVID? If you're hypoxemic, dex and remdesivir. If you're on the vent and you're short on remdesivir, consider not using it, although again, there still needs to be some more study of that. The role of convalescent plasma is still unknown. It is probably safe, but we still lack randomized controlled trial data. It appears that 5 days of methylprednisolone, at least in the trial in Brazil, may be inadequate, but my personal appeal would be to master the basics first, right? Low tidal volume ventilation, aggressive VTE prevention, strict attention to infection control, and I think that will be most likely our way forward. So thank you very much again for the opportunity to speak with you today, and best of luck to all of you, and please stay safe.